I'll have just a small talk on recirculation. Most of the aspects we have already discussed. There's few things not been discussed, so I'll discuss that. After that, I'll just do a revision of whatever we've done. So I'll just give you take-home messages, and then that will be followed by your exams. So recirculation is oxygenated blood from the returning cannula goes back to the drainage cannula without going to the systemic circulation. It is more seen with a single side duodenal cannula is not properly placed, or both the draining or returning cannula are close to each other. 30% of recirculation is average. Decreases the efficacy of PV supports, and the clinical diagnosis by decreasing the venous arterial saturation, increasing the pre-membrane saturation. That will tell you the recirculation is increasing. And this is what the recirculation is. Whatever the returning blood goes back to the same. Slide I already shown it to you. Not the proximal. That in double lumen catheter, there are three ports. One, the drainage port from the SVC, one drainage from the IVC, and the returning port in the mid-RA. Okay. So this is what I have shown you. See the drainage cannula is properly placed. Return cannula has come down a much. Ideally it would have been here, and that is what leads to recirculation. So how can you detect recirculation? By seeing the cannula position, by visual inspection of the tube colors, okay, by seeing the difference between the venous saturation of the circuit and the PO2 of the patient, oxygen transfer, and thermodilation method. Okay. So this is what I shown in the slides. If both the cannulas are very close to each other, you are going to see the recirculation. This is no recirculation. Here there is recirculation. And this is the formula. How will you calculate recirculation? You have a pre-ox saturation minus venous saturation and post-ox saturation minus venous saturation. So if you have pre-ox saturation for 90, that itself means that the patient has got a recirculation. So 90 minus this venous saturation and 100 minus venous saturation, the fraction of that will calculate the recirculation. Since the recirculation is more, then you need to do something for the recirculation. The problem is measuring the mixed venous saturation. As I told you, if you are taking from jugular vein and that is close to your returning cannula, you may not get an accurate venous saturation. So that is going to be a problem. But then what we usually do is then we collect it from the femoral vein. Now you can bedside, you have to quantify the recirculation during venous ECMO, but that is still not available by the saline dilation method, ultrasound method. But that is not available in India. So you can have a online monitoring of the recirculation. Now what are the factors which affect recirculation? One is the pump flow. Second is catheter position that we discussed already. Cardiac output and right atrial size. So that is one thing. Basically the intravascular volume. So recirculation flow increases almost linearly with the increasing pump flow. So as the pump flow increases, the recirculation chance increases linearly. Your ideal pump flow rate provides the highest effective pump flow rate at the lowest RPM. That is an ideal. So with the minimum RPM, whatever the highest saturation you can get, that is an ideal your pump flow. Okay. So effective pump flow equals to total flow minus total flow multiplied by the recirculation fraction, and that is the way you can calculate the effective flow. As the pump flow increases, the effective flow first increases, then stabilizes, and then decreases, and that is what we call as the defining curve. And that is what I was telling you. See, if you see the effective flow, when the pump speed increases, the effective flow increases initially, but at one particular point it comes to stagnation. So even if you increase the pump flow, your effective flow will not increase. Rather, it will cause more recirculation, and because it causes more recirculation, what will happen is the flow, your saturation will decrease. Is this clear? So it's not necessary that when you increase the flow, the saturation will improve. Saturation will improve to one extent. but at particular extent, the saturation will become stabilized, and then the recirculation will be more and more, and that will lead to decrease in saturation because the recirculation increases. And that's the reason whenever you see a recirculation, what you do first thing is you decrease the flow. Suppose you are on 5 liters of flow and you see the recirculation. You see the saturation has dropped. Forget about calculating recirculation. You see your saturation has dropped. Say your saturation 90 with 5 liters of flow, the saturation becomes 88 or 85. What will you do? You will decrease the flow from 5 liters to 4.7 liters. Decrease the flow by 250 or 300 ml and see what happens. If your saturation remains the same, in that case, if your saturation improves. If saturation improves, it means that there was recirculation. And if saturation remains the same, that means you still don't require 5 liters of flow, you can manage with the 4.7 liters of flow. So that way you can keep on coming down on the flow till the time the saturation start dropping. Understood? That is what we call as a defining the curve. That is what we call as and that situation we keep on varying person with time to time in the same patient because of patient position. Suppose patient position varies, this recirculation can change. So that's the reason whenever the patient's saturation drop, what you need to do is you have to decrease the flow a bit and see what happens. If the saturation remains the same or increases, keep on doing that till the time the saturation start dropping. Okay, that is what we call the defining the curve. If recirculation is high, SpO2 85, pre-membrane saturation 86, minor saturation 53, win the pump flow. If patient saturation improves or stays same, win again till you get the best SpO2. If they decreases, go back to the flow and seek other causes of recirculation. Okay. So catheter position, if it is single site, again if the catheter is moved, you get to see recirculation. If two side, if the drainage is from the RA and returning to the femoral vein, again recirculation is more as compared to you drain from the femoral and return to the RA. Okay. And catheter position can change when the degree of lung infection changes, neck edema increases, and patient moves. And this is more common in pediatric groups. So you have to be more careful when you put a double lumen line in the pediatric groups because it can change. And the moment it change, the patient will desaturate. So that's the reason you have to be mindful about it. How you diagnose it? With the help of X-ray chest and do a 2D echo, and then you can get to know your catheter result, your cannula is moved or no. And what we do is, if catheter position is problem, try repositioning the patient with the cannulas. Okay. So you can give some position to the patient, and that if that position the cannula remains stable and recirculation decreases, that's fine. Or you have to change the cannula position. If that does not help, then what you have to do is you have to go for a additional one more cannula, VVV cannula, and ideal for VVV is cephalate vein. See, this catheter is moved a bit up. So what happens? The IVC is running from here, return is going here also, here also. So what will happen? This will lead to recirculation. Can you see this? This is the IVC port for drainage. This is the SVC port for drainage, and this is going to be the RF. Basically, the return port which will go directly to RA to the tricuspid valve. And then the recirculation depends upon the cardiac output and the volume status. If the cardiac output increases, the cardiac output is adequate, the blood flow is good, so there is a less recirculation. If there is a standstill, the cardiac arrest, there is 100% recirculation. Because the valve is not opening, there is 100% recirculation. So if the volume stress is low, again the recirculation will increase. So if the cardiac output, if your heart rate also increases much faster and your valve opening time is less, again there will be a more recirculation. So you have to always keep that in mind about the recirculation. Since there's a tachyarrhythmias or there's a bradyarrhythmias, recirculation chances will increase because the valve opening will not be there. So if there's a tachycardia, adequate stimulation, minimum stimulation, okay, or if there's tachyarrhythmias, you have to convert the arrhythmias, because till the time you don't convert the arrhythmias, recirculation will not improve. And last, if nothing is helping, you have to add more and more cannula for the drainage. Cannula can be added in IVC or SVC and preferred this separate cannula. Okay. This should be an ideal, as I told you, left femoral for drainage, right jugular for drainage, and keep this for a returning cannula. So what you need to do is you have to you are using for drainage, just push it bit inside to the RA, use it as a return. Use this jugular cannula which you are using for a return now, use it for a drainage, and put additional cannula in the femoral vein, and that also you use it for a drainage. That would be an ideal thing. Vein. This is VV ECMO, na? VV. See, that's not that will be dependent upon the preload and the cannula size. So that doesn't make a difference basically how much it is coming from each side. So ideal would be a cephalic cannula because decreases the recirculation chances, increase the amount of oxygen added per pass. It augments the venous drainage from the brain, and continuous measurement of cerebral saturation is also possible with the help of cephalic cannula, but it is more said theoretical rather than been done practically. And last resource is conversion to VA.